उद्धार करथिले वेद ज्ञानर भंडार कहा जाए महोदधि हेउची माँ महालक्ष्मी बाप घर तेणु श्री पुरुषोत्तम क्षेत्र पवित्र शंख क्षेत्र पवित्र श्रीक्षेत्र और महोदधि पवित्र मिलन घटी ए पवित्र श्रीक्षेत्र श्रीक्षेत्र पंचतीर्थ परिकल्पना करिसंती प्राचीन मनीषी माने।
It is with immense pleasure and honor I welcome you all to this grand physiotherapy gathering, Srikhetra Physio Manthan 2024. This gathering presents a unique opportunity for us to delve into multifaceted world of physiotherapy, exchange knowledge, and collectively elevate the standards of our profession. First and foremost, I would like to express my gratitude to each and every one of you for taking the time to join us today. Your presence is a testament to the growing importance of physiotherapy in modern healthcare. This conference is a collaboration of our profession and a recognition of the incredible work that we do. This conference also provides a unique opportunity for us to collaborate and network with experts from other medical specialties. We are delighted to have with us today renowned doctors from the fields of orthopedics, neurology, cardiology, gynecology and so on, who will share their perspectives and on the role of physiotherapy in interdisciplinary care. Upon our dignitaries and welcoming our guest of honor, Dr. P.P. Manthan sir. Ladies and gentlemen, it is an absolute privilege to introduce someone who has not only excelled as a physiotherapist, but has also shaped the future of this field. Over 25 years of academic experience with PhD. He has more than 100 scientific publications. He specializes in rehabilitation and musculoskeletal disorders, contributing significantly to national and international research. He is highly accomplished director and PhD scholar. I request a big round of applause for P.P. Manthan sir. Ladies and gentlemen, it is an honor. We are delighted to welcome Dr. Sandeep Singh sir. He is a highly skilled and accomplished orthopedic surgeon specializing in robotic care with extensive experience in leading hospitals across India and the UK. He is known for advanced techniques in joint replacement and sports injury. Request for a big round of applause for Sandeep Singh sir. Distinguished neurologist whose expertise and contributions have set a gold standard in the field of neurology. Bhubaneswar. He is renowned for his excellence in epilepsy, stroke and advanced neurological therapy. Please give him a big round of applause. Rajya Sabha has arrived, so please welcome him with a great round of applause. He is the head of the Department of Physiotherapy at Manipal Hospital, Bhubaneswar, with over 16 years of experience in orthopedics, pain management and sports rehabilitation. He is a PhD scholar. He has published more than 15 scientific papers advancing physiotherapy research and practice. So please welcome effective patient-centered care. Her expertise. Last not the least, I would
आउथरे आपण मानक प्रणाम करूछे श्रीक्षेत्रालयर सहयोगरे श्रीक्षेत्र फिजियो मंथन 2024 कार्यक्रम आउथरे अतिथि मान तथा मुख्य अतिथि माननीय माननीय राज्यसभा सांसद सुभाषिष खुंटिया महोदय को अनुरोध करी एवं तत्सहित समस्त अतिथि माने महाप्रभुंकर पाद पद्मरे आज उद्घाटित हेउची ए मनोज्ञ कार्यक्रम श्रीक्षेत्र अन्यतम पवित्र तीर्थराज महोदधि जेते तीर्थ जेते पीठ सबु सेई महाप्रभुंकर उपस्थिति लागी
आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्मः दीपो हरतु मे पापं सन्ध्यादीपनमोस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्यब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रास्य
महाप्रलय समय महाप्रभु एठारे मीन रूपरे बेतर स्थान पाइछि महोदधि को महालक्ष्मी बाप घर तथा श्री जगन्नाथंकर ससुरालय बोली मध्य कह जाय थाए आज उद्देश्य हेउची स्वास्थ्य सेवा समुच्चय थीम रही फिजियोथेरापी टू फिजियोपैथी एक नुआ अध्याय जो माने भावरे हमर अछंती डॉक्टर अम्लान ज्योति महांती आम सहित साधारण संपादिका भावरे डॉक्टर शिवानी शंकर त्रिपाठी साधारण संपादक भावरे डॉक्टर अमूल्य कुमार पृष्टि साधारण संपादक भावरे अर्पण करुछि स्वागत करुछि निमंत्रण करुछि आपना भितरे सारा जगत को कार्यक्रम पाई मु अनुरोध करुछि ए बिंची देबे भाई भाई भाई
Hello. Jai Jagannath. Good morning, everyone. It is my great honor, proudly organized under the Indian Association of Physiotherapy and Health and Harmony. The theme of the year is Physiotherapy to Physiopathy, a new era. For awareness, knowledge and neuro, cardio, obstetric and gynecology and orthopedic conditions with physiotherapy rehabilitation for society. Reflects our commitment to advancing our field and contribution to a healthier, more informed society. We as physiotherapists are not only just healers, we are educators, innovators and partners in health. Today we aim to bridge the gap between therapy and pathology, bringing deeper awareness to how physiotherapy plays a vital role in addressing and rehabilitating complex conditions. Whether it helps a child regain mobility, aiding a cardiac patient recovery, or empowering mothers post-delivery, or scope in vast and impactful. I'd like to take this opportunity to thank the Indian Association of Physiotherapy for their continuous guidance and support in bringing us together. This event is not just a gathering of professionals, but a celebration of our shared vision effort to make physiotherapy accessible, effective, and revolutionary to all dignitaries, panelists, and participants here today. Thank you for contributing your time, energy, and knowledge. Your expertise will undoubtedly enrich our understanding and inspire us to push our boundaries. Let us all take this day to learn, share, and grow together. By doing so, we will not only strengthen our profession but also make a lasting difference in the life of people. Once again, I welcome you all and wish you all productive, insightful, and inspiring day ahead. Thank you. I also invite all the dignitaries to the stage, and I thank everyone personally to making themselves available on the last day, like the last Saturday of the year, to this event. Thank you, everyone. Jai Jagannath.
Thank you so much, sir. Now, I would request Dr. Sandeep Singh, sir, to kindly share a few words.
Come to a conference which is on a beachfront, so I really like it. So before I start, I would like to especially thank Amlan and Dr. Shivani and Dr. Amlan for organizing this kind of an event, because I personally feel as an orthopedic surgeon that physiotherapists and surgeons, the correlation and the symbiosis which should be there, it's not there in Odisha as much, and we are trying to develop it very hard. And that relationship will only develop from two ends. It will not develop from the surgeon end, it will not develop from the physiotherapist end. It will develop from both ends. ମୁଁ बहुत frankly कही दूची कि जदि गोटे डॉक्टर भलरे ऑपरेशन करूची मु बेस्ट नी रिप्लेसमेंट भी कर देली, बट जदि तापरे तारो फिजियोथेरेपी होउनी, then that surgery will be unsuccessful, the surgery will not do well. केबे केबे कोन होची कि जदि मु ऑपरेशन बहुत भलरे करिनी, अराउंड 80% भलरे करूची, बट जदि भलरे फिजियोथेरेपी हे जाउची, that surgery will do well. So that is the power of physiotherapy. Now very few doctors and very few surgeons understand to establish this. तो आमे जेबे भी अमलान संगरे की शिवानी संगरे कथा होचु, आमे यही कथा होचु कि how do we develop this symbiosis more, how do we develop this interpretation more. Through this channel, through this podium which I have got, I would like to again thank these two people for organizing these kind of events. I also personally want to do more of these events so that this symbiosis and this condition of not working together changes and we work together more. I feel that all of you have come from different parts of Odisha, and different parts of Odisha has the same issues. Somebody who has come in from Koraput will have the similar kind of patients who are from somebody who is from Bhubaneswar. If all of us get together and make some kind of synergy, I will not take too much time now because I think we have to move to the panel discussion. I would just end by thanking again Amlan and Shivani for organizing this amazing program, and hope to see more of this. Thank you. Jai Jagannath.
Thank you so much, sir. Now, I request our guest of honor, Dr. P.P. Mohanty, sir, to please share his few words.
Namaskar, respected Chief Guest, Mr. Subhasis Kuntia, Member of Rajya Sabha, and all the other dignitaries on the dais, all my physio friends, very good morning to all of you. प्रथमे आयोजक मानक मोर बहुत बहुत धन्यवाद. डॉक्टर शिवानी रीतिमत भाव में एमती प्रोग्राम अरेंज करी आसुचंती आमर फिजियोथेरापिस्ट मानकर रिफ्रेशमेंट पाई तांको मोर आंतरिक धन्यवाद. डॉक्टर अम्लान भी बहुत फिजियोथेरापी अपग्रेडेशन पाई काम करी आसुचंती, सेमानको मोर बहुत बहुत धन्यवाद. रिगार्डिंग फिजियोथेरापी, यू नो फिजियोथेरापी ओडिसा रे 1987 आरंभ होता बहुत कम समय भितर तार जो इम्पोर्टान्स टाको सोसाइटी रे जाहिर कर पारी. फिजियोथेरापी केवल रिहाबिलिटेशन नहीं, यूजुअली लोक मैंने भावती एटा रिहाबिलिटेशन प्रोफेशन, किंतु हेल्थ प्रमोशन एवं प्रिवेंशन ऑफ इंजुरी, फिटनेस, वर्क रिलेटेड प्रॉब्लम रो प्रिवेंशन पे फिजियोथेरापी इम्पोर्टान्स बहुत रही. WHO कहूँ 21st century stress is going to be the greatest killer. Work related occupational problems are going to be the big problem in the society. So to tackle all these problems, physiotherapy play a very important role. Then physiotherapy द्वारा जो रोग भल हुए सेटा भी सोसाइटी लोक मैंने भीतर गोटे अवेयरनेस क्रिएट है जहाँफल कि मस्कुलोस्केलेटल जो ऑर्थोपेडिक मेडिकल कंडीशन आसूची लोक मैंने डायरेक्टली फिजियोथेरापी को पाखक आसीपार। डॉक्टर संदीप जो भाई भाव में कहले फिजियोथेरापी और ऑर्थोपेडिक सर्जन भितर गुड रिलेशन हवा दरकार। आई रियली थैंकफुल टू डॉक्टर संदीप सिंह because that is the truth which most of the people do not accept, but that is the truth. No surgery can be 100% successful without coordination between the two professionals. Similarly, in neurology also समस्त neurological condition में physiotherapy importance रही। Most of the cases, physiotherapy play a very important role in neurological condition, whether it is neuromedicine or neurosurgery. Similarly, obstetric gynecology during pregnancy to prevent various musculoskeletal problems, and for the easy childbirth, physiotherapy also play a very important role in all the field, starting from mother's womb till death of the individual. Physiotherapy play important role, not only by treating the person with disability or disorder, it also play a very important role in normal individual. Every individual, I'll say, requires some or other kind of physiotherapy as a preventive measure to keep oneself fit. Again, organizer मान को मोर बहुत बहुत धन्यवाद। पार्टिसिपेंट माने आज आसी जो विभिन्न कर्नर ओडिसा आसी से को स्वागत करा जाउछि। आउ टिके अधिक पार्टिसिपेंट हेतिले बोधे प्रोग्राम टा बहुत बढ़िया होता। धन्यवाद।
Thank you so much, sir. The whole Physio fraternity is blessed to have a person like you. Now, I request Dr. Surya Prakash Chaudhary, sir, to please share a few words.
नमस्कार, जय जगन्नाथ। आज ए पवित्र माटी रे सागर कूल हेल्थ एवं हार्मोनी एवं इंडियन एसोसिएशन ऑफ फिजियोथेरापी मिलित चेष्टा जो कॉन्फ्रेंस एठी आयोजन करा जायछि तार समस्त कर्मकर्ता एवं समस्त आयोजक मानकु मु बहुत बहुत धन्यवाद जणेबी। स्पेशली डॉक्टर अम्लान, डॉक्टर अमूल्य, डॉक्टर रश्मि, डॉक्टर शिवानी समस्त धन्यवाद जणेबी। मते आज गोटे एभली जगार गोटे अतिथि एवं वक्ता हिसाब से निमंत्रण करथिबारु मु जने न्यूरोलॉजिस्ट न्यूरो फिजिशियन आपन कहि परिबे। जदि किए मो प्रेस्क्रिप्शन आपन देखिचंती प्रथमे देखिथिबे मोर प्रथम एडवाइस था फिजियोथेरापी। फर्स्ट मु फिजियोथेरापी लिखिबी, तापर मो प्रेस्क्रिप्शन लिखि आरंभ करिवि। नंबर 1, नंबर 2, नंबर 3 मेडिसिन। काहेकि ना न्यूरोलॉजी एमती गोटे रोग ए टू जेड जे कोनोसी डिजीज कहिबे से डिजीज फिजियोथेरापी रो रोल ही रोल अछि। बिना फिजियोथेरापी रे न्यूरोलॉजी रो कोनोसी ट्रीटमेंट संभवपर नुहे। आपण जेते मेडिसिन खाइले भी आपण स्ट्रोक टू आरंभ करी आपण पार्किंसन डिजीज टू आरंभ करी ट्रेमर, अटैक्सिया, लंबर स्पॉन्डाइलिसिस, सर्वाइकल स्पॉन्डाइलिसिस, न्यूरोपैथी, मायोपैथी, मस्कुलर डिस्ट्रोफी, लिस्ट नंबर ऑफ लिस्ट आर देयर। जदि मु कहिबी फिजियोथेरापी रो बहुत किछि माने तार मूल्य रहिछि। एवं ई जो फिजियोथेरापी किबा फिजिकल थेरापी कहीदेले तो दीटा वार्ड लगुच। ये दीटा वार्ड को लेकिन आजिकल लोक मैंने गोटे बिजनेस भी आरंभ करदे। आम कि समय डॉक्टर शिवानी सहित मुझे कथा होती आपन जुआड़ जी गाँ गहली क्वाक मैंने समस्त फिजियोथेरापी करवा स्टार्ट कले। मैंने जहाँ भी हो फिजियोथेरापी तो चलती आउ कौन से कौन होची कौ मेथड रोची कौ रोग कौन दरकार कहीं किसी बुझुना समस्ते फिजियोथेरापिस्ट आज हो गले। तार रिजल्ट जो पेसेंट आम पाक 1 month 2 month पर आसूची तार रिजल्ट कौन रोची से पेसेंट के पेन आग्रावेट होची डिजीज केते सीवियर हो जाउची सेटा हमें देखुचे। तो आज यही कॉन्फ्रेंस किंबा मुझे कहबी कॉन्फ्रेंस अपेक्षा मोरिटोफोन अवेयरनेस जो आमर ओडिशार कोण अनुकोण सब फिजियोथेरापिस्ट आसी एठी आमे गोटे ज्ञान आलोचना हम। एठी ना कि मु बहुत किसी कहीदेवी बहुत किसी जानी आपण मैंने मत शुणे सेमती किसी ना। मेडिकल साइंस एमती गोटे साइंस सारा विश्व में जोटी कहीं केवे सब किसी जानी था। स्टिल आई एम लर्निंग। आपण माने भी शिखुचंदी आमे भी शिखुचे। तेणु आम गोटे मुझा जोटा जानी कहि आप जोटा जानी मत कहे मोर भी फिजियोथेरापी नॉलेज नहीं मुझे जहाँ भी किसी सांग मान शुणी फिजिकल थेरापी ऑक्युपेशनल थेरापी सीबीटी थेरापी स्पीच थेरापी तो यही सब विषय जहाँ नॉलेज अच्छी मुझे किसी ज्ञान नेबी आपने किसी ने यहाँ गोटे मैंने ज्ञान गोटे आदान प्रदान हम ये किसी कन्फरेन्स नहीं कि भाषण मारे आप शुणे तेणु समस्त कंट्रीब्यूशन यही कन्फरेन्स को आज आम जो संध्या 7टा पर्यंत चलो समस्त अवदान निहात दरकार समस्त माने सहयोग करेंगे बोली मोर आशा रोची केमती आम यहाँ को भल भाव सफल करवा एवं यही वार्ता को जो मोर मीडिया भाई बंधु मैंने आसी से माने यही वार्ता को एमती कोण अनुकोण ओडिशा रे पहुंचंतु जो माने लोक बुझंतु जे फिजियोथेरापी किंबा फिजिकल थेरापी रो कोन तार मूल्य रहउची मु तो मो रोग कथा कहि देले आपण जे कोन जहां भी मु रोग कहली मते भी लोक पेशेंट पसंद से आपण कदुना एक्सरसाइज हम कर दउ मु लागे मु कहि परिबिनी मु से जिंसर मास्टर ने मु शिखिची न्यूरो फिजिशियन मु मेडिसिन लिखिबी मु से पाठ पढी के आसी न्यूरो सर्जन सर्जरी करबो बट न्यूरो फिजियोथेरापी से माने आपण को फिजियोथेरापी करिवे मु 2 मिनिट रे आपण कहि देबे गोड़ भांगी पेट भांगी पिठी भांगी से किसी लाभ हेनी आप 15 दिन पर पुणी पेन बढ़ी जाइए तेणु आप गोटे प्रॉपर फिजियोथेरापी देखा करूँ दे विल गाइड यू सी आप गाइड कर कौन कर कौन डिजीज अच्छी कौन अच्छी एमआरआई देखिए एक्सरे देखिए कौ जगह केते डिग्री रेंज ऑफ मूवमेंट दरकार केते स्ट्रेचिंग दरकार केते समय पे दरकार तो से एडवाइस करेंगे सो आमर भी मटो यह दरकार आपण मानक भी मटो यह दरकार तेणु एति जदि आम भर कोऑर्डिनेशन हम निहाती भाव में आम फिजियोथेरापी को बहुत आगू को आम पहुँचे पारे जहाँ आज मोटो रही फिजियोथेरापी टू ए फिजियोपैथी जो आपंकर मोटो रही निहाती भाव में बहुत सफल हो बोली आशा करी कहबी धन्यवाद वंदे उत्कल जननी जय जय
स्पेशली सार को धन्यवाद देवी एते कम समय भितर आम डाकिलु आ सार मैडम मोना मैडम आम पाखे आज अच्छा प्रेजेंट अच्छा यहीटा आम फिजियो मान सबुठ बड़ गोटे गर्वर कथा जे आज आम भगवान को आम पाखे पाइचे आम तो एमती सार को देखुचे हेले किंतु आमर ये जो छोट उद्यमटा आम कलु विश्वास करूँ 7 दिन तले प्रोग्राम रो जन्म मात्र 7 दिन भितर अम्लान अमूल्य शिवानी आशीषा संध्या 7टारू संध्या 12टा 11टा केते बीती जाइए प्रोग्राम को सक्सेस करने आज खुशी लगुच डाइस उपर एते बड़ बड़ दिग्गज मान को देखिकी जे आमर छोट उद्यमटा आज सफल हो गला भगवान जगन्नाथ को धन्यवाद देवी सी भी आम सांगे आज अच्छा आमर ये कार्यक्रम को सफल करने अम्लान टिके डरी जाइथिला कौन हम सांग कहली भगवान अच्छा आम पुरी रे करुचे निश्चित सफल हम तो आम फिजियोथेरापी कौन आवश्यक कौन डॉक्टर मानकर हेल्प से सब तो आम डिस्कसन आज हम किंतु आम आम जो अच्छी फिजियोथेरापी यूनिट आमे सब चेष्टा करबा आमे केमिति आम निज डिग्निटी बजाई रखिबा आमर निजर जो कहती ओजन आम फिजियोथेरापिस्ट आमे गर्व कहू पारिबा कहबा भी कहीं कहबानी तो पीपी सार सब बेले आमको साहाय्य करि आसी साहाय्य करूछंती आशा करी सी आम उपर एमती आशीर्वाद करी रखी था ये छोट प्रोग्राम आगु को आहुरी आगु को जाऊ आम प्रति वर्ष एमती प्रोग्राम करूँ से आम सुभाषिष सार को भी धन्यवाद देवु सी आम उपर भी एमती आशीर्वाद करि थांतु जे पर्यंत सार पुरी रे अछंती आमे से पर्यंत एठी सब वर्ष जमती सार करिवु एति आम आपन को रिक्वेस्ट करिवु आपण हमको सब वर्ष अलाउ करिवे एठी करबा पई एमती प्रोग्राम आमे आपन को सार प्रतिश्रुति दबु ए प्रोग्राम अल्प समय रे हेची तेणु किछि जदि भूल चूक हे जिवो आम मन को क्षमा करिवे किंतु आर वर्ष सर आहुरी बहुत बढ़िया करू थैंक यू एवरीवन प्रेजेंट ऑफ योर माय जूनियर्स माय सीनियर्स एवरीवन थैंक यू प्लीज गिव अस अ बिग राउंड ऑफ अप्लॉज फॉर आवर गेस्ट सूर्य सर तो बहुत कहिबे संदीप सर भी कहिबे तो आम समस्त आज एक्साइटेडली सुनिबा से मानगठु थैंक यू सो मच
आजिका श्रीक्षेत्र फिजियो मंथन 2024 एक कार्यक्रम को आयोजन करिथिबा मोर पुरीर बड़ भाई मोर बंधु अम्लान बाबू उपस्थित समस्त डिग्निटोरीज ऑन द डायस एंड ऑफ द डायस डॉक्टर संदीप सिंह जी डॉक्टर पीपी महांती सूर्य प्रकाश जी रश्मिरेखा महांती और उपस्थित ओडिशा सारा आसीथिबा फिजियोथेरापी भाई और भौणी माने आपन जदि किछि माइंड न करिवे टिके मु समस्तंकर परिचय नै परिबी प्लीज किए अच्छा आपण मैंने फिजियोथेरापिस्ट ओडिशा रु आछंती मुझे जानिबा पई चाहे आउ 5-10 मिनट पर आम डिस्कसन भी करी आपण सहित।
नमस्कार सर मु डॉक्टर तापस मित्र मु वर्तमान नेशनल ऑर्थोपेडिक सेंटर अछि भुवनेश्वर।
डॉक्टर सिद्धार्थ शेखर पात्र मु डीएचएस पुरी रे जॉब करछु।
सर मु शशांक डीएचएस गंजाम।
सर नमस्कार मो ना प्रियव्रत कालीकुमार ओझा मु पट्टामुंडई एसडीएच रे फिजियोथेरापिस्ट।
नमस्ते सर मु डॉक्टर प्रोफेस पात्र कंसल्टेंट यूपीएससी पावर।
नमस्कार सर मु अमरेंद्र साहू फ्रॉम ऑनबोर्ड।
Good morning, sir. Myself Pratima Kumari. I am working as a physiotherapist in Urban Health Wellness Center at Jajpur. Thank you.
Myself Dr. Krishna Agrawal. I am from Angul, working at my own clinic.
I am Dr. Jitendriya Prasad Misra. I am pursuing my own clinic at Khordha and also course coordinator at Vishwas College of Physiotherapy.
Good morning, sir. I am Dr. A. Tanaya, working as an associate professor in High Tech College of Physiotherapy.
Please.
Good morning, sir. Myself Dolly Das, working in District Headquarter Hospital, Kyonja.
गुड मॉर्निंग सर माइसेल्फ अरूप बल आई एम वर्किंग मणिपाल हॉस्पिटल भुवनेश्वर।
आई प्रियरंजन साहू वर्क एट फिजियो हैंड रिहैब सेंटर।
Myself Pallav Barar Singh. Morning. Myself Smita Rani Behra. I am working at Keunjhar, MR Child Specialist. Yeah.
Good morning, sir. I am Dr. Deepak, Junior Physiotherapist at Eureka Healthcare, Kotak.
Good morning, sir. My name is Deepika Pradhan. I am working Bhubaneswar.
Good morning, sir. Myself Dr. Nirmala Chandan, Head of the Department IMT Physiotherapy College, Puri.
नमस्कार सर मु मनोरंजन दास।
Good morning, sir. Dr. Naik, Jagatsinghpur DIC रे अछि।
सर नमस्कार मु श्रीकांत पात्र कोरापुट डिस्ट्रिक्ट रे आसी डीएचएस 9 जय जगन्नाथ सर मु स्वागत पडियरी जगतसिंहपुर निजर ओन क्लिनिक प्रैक्टिस करछु।
गुड मॉर्निंग सर माइसेल्फ भानुव्रता फ्रॉम बरहमपुर।
ठीक अच्छे धन्यवाद समस्त को। आउ पछरे किए अच्छा जल्दी जन कही दिंतु खाली कोट कोट आछंती।
नमस्कार सर आई एम तन्मयी पटनायक वर्किंग एट सालेपुर CHC कटक।
सालेपुर।
गुड मॉर्निंग सर माय सेल्फ डॉक्टर आकांक्षा राय फ्रॉम IMS एंड फॉर्म 2।
थैंक यू टू ऑल। कहीं आपण मानकर परिचय नेली मोर जानिबार आवश्यकता रही जे को एठी लोक माने अछंती को जगह को रिप्रेजेंट करछंती कहीं कथा कहली आम मानक भितरे गोटे अवेयरनेस रो आवश्यकता रही जे फिजियोथेरापी माध्यम रे केते गोटे रोग भल होई पारुची बिना कोनोसी औषध रे से ना होम्योपैथिक ना आयुर्वेदिक ना एलोपैथिक। वर्तमान जो युग खाद्यपेयर ठीक ठिकना नहीं आमे चाहिए भी ठीक समय खाई पारनु विषाक्त खाद्य नौछु तेणु आमर जो शरीर चर्या रहिबा कथा ताकू आमे मेंटेन करि पारना जहाँ फल कि आमर ऑर्थोपेडिक डॉक्टर अच्छा आमर न्यूरो डॉक्टर अच्छा आमर फिजियोथेरापी भाई मैंने आप बस आपण मान पाखक आम बारंबार जावाक पड़ुछि आपण मानकर परिचय नेली एइथपई मु जो मंच को जाए सदाबले मो भितर गोटे कथा थाए से मंच से अनुष्ठान से एसोसिएशन कहीं मते डाकी तांको पाई मोर कर्तव्य कौन अच्छी मु सेथिपई आपण समस्तंकर परिचय नेली जदि मु कोनोसी भूल करथि मते क्षमा करिवे काई के कथा कहली आपण मानकर कौन कौन आवश्यकता रही कौन फिजियोथेरापी डॉक्टर मानकर दरकार आपनकर इंफ्रास्ट्रक्चर दरकार आपनकर इक्विपमेंट दरकार आपण मानकर एसोसिएशन घर दरकार कि आपनकर पब्लिसिटी हवा दरकार कि आपनकर जो व्यवस्था रे आपण चली आपण मानकर क्लिनिकली एस्टाब्लिशमेंट ठू आरंभ करी आपनकर मेडिकल सहित कोऑर्डिनेशन ठू आरंभ करी आवश्यकता सेथिपई मु आपण मानकर परिचय नेली जदि स्टेज रे जो भाई माने बसचंदी ऑर्थोपेडिक डॉक्टर तंका कथा कहिले न्यूरो डॉक्टर तंका कथा कहिले मु किंतु आशा करूथली जे आपण मानक भितरु मु जण को निवेदन करिवि आपण मानकर कोन समस्या रहिछि को कामटी को कले लोक मानकर सेबारे आपण अधिक लागि परिबे को लाकुना आपण पाखरे नाही से कथा जदि जणे आपण भितरु के आसी मते टिके कहिबे मु अधिक खुशी हेबी महाप्रभुकर आशीर्वाद रु श्रीक्षेत्र पुरी एपरी एक जगह आपण अनेक जगह देखा पाउथिबे तीर्थ क्षेत्र अनेक जगह देखा पाउथिबे पर्यटन क्षेत्र श्रीक्षेत्र पुरी पर्यटन आ तीर्थर मिलन स्थली सबुठ बड़ कथा महोदधी कूल कार्यक्रम होईची आ पुरीर समस्त उद्योक्ता माने जो माने अम्लान बाबू आरंभ करी मैडम माने शिवानी मैडम मु जहाँ ना शुणुली समस्तंकर सहयोग रे कार्यक्रम होईची ए कार्यक्रम को आपण व्यापक करंतु सेति जहाँ आवश्यकता मो तरफ मु निश्चिंत आपण मानकु सहयोग करिवि आ समस्त गोटे कथा आपण को कहि रखिया पई चाहूची आपण मानक भितरु जदि जणे के अछंती आपण मानकर कोटा डिफिकल्टीज रही से डिफिकल्टीज की जदि मु सॉल्व करि पाली मु निश्चिंत ए आज कार्यक्रम को आसिक निजको धन्य मन करी जणे कि आपण मानक पाखक आसंत डॉक्टर माने अछंती आपण मानकर कोन आवश्यकता रही आमे सही अनुसार करबा कारण सीएसआर हेड रे गुडे कार्यक्रम करबा पई आमे चेष्टा करूछु तेणु अम्लान बाबू दयाकोरी टिके कहिले भल हम धन्यवाद वंदे उत्कल जरणी
थैंक यू सर 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 आम बहुत धन्य मन करमको एत प्रायोरिटाइज करके आम प्रोब्लेम गुड़ा आप शुणा समय दौरान समस्त को जन जन शुणिले सर तादरे वी आर वेरी मच टच्ड ये दब आउट ऑफ एक्सेप्टेंस वंस सॉल्यूशन पाइले से सॉल्यूशन को सम्मान देवे तो दैट विल कम बाय डिफॉल्ट सेटा हमें चाहिए भी किए कि सर टिके गोटे सेफ और सिक्योर्ड एनवायरनमेंट जो सब काम करेंगे समस्ते तो कम्युनिकेशन स्ट्रांग ना समस्ते पाठ एका जानी किंतु सर काम कला बेलू क्या डेलीवरी कौन टिके गोटे कॉमन प्लेटफॉर्म समस्त को हेले सर टिके सुविधा हम आपण खाली सर आशीर्वाद रखु जगन्नाथ आशीर्वाद एमती था सर यहाँ प्रथम थर आम आरंभ करूँ दिस इज फर्स्ट टाइम इनिशिएटिव कि जोटी आम परस्पर कम्युनिकेशन करूँ चेष्टा करूँ सर प्रति 3 मास थे प्रोग्राम करूँ वर्षक थे मुझे कहबिनी वर्षक थे बहुत दूर हो कारण या द्वारा लोकंर एक्चुअली बेनिफिट केमती हम ताऊपर आम कम करूँ पेसेंट वेलनेस या पर सर आम डॉक्टर
कि बसवा घरटे आवश्यकता रही जो एकाठी गेट टुगेदर हो पारे आपण मैंने जगह ठीक करूँ सांसद को पांठि घर तैयारी अर्थर साहाय्य मुझे जोड़देवी धन्यवाद
बहुत बहुत धन्यवाद सर बहुत बहुत धन्यवाद सब सर आपण ऋणी है सर थैंक यू
आपण मानकर जदि समस्या रहिबो से समस्या को जदि मु गोटे भी समाधान करि पारली ए मंच को आसीबार मोर प्रकृत मूल्य रहिबो जहाँ कहले अम्लान बाबू जे आपण का एसोसिएशन न बसिबा पई व्यवस्था सांसद को पाठरू अर्थ जोगै देबा पई कथा हला सेकंड कथा रहिला आपण जो सैलरी कथा रहउचंदी जदि अलगा राज्य दउचंदी व्हाई नॉट ओडिशा आपण माने जेहेतु आपण माने जानुथबे सांसद कर काम नेशनल हेल्थ मिशन आपण एनआरएच अछंदी ना रूरल हेल्थ मिशन एबे एनएचएम हे जाईची तेनु आपणकर आमको देले एटा को आमे गोटे क्वेश्चन भी करि परिया पार्लियामेंट रे आपण मते गोटे ग्रीवांस लेखि की दियंतु आपण का एसोसिएशन तरफरु तापर आमे बसी के आलोचना करिबा एटा कोन करा जाई परिबो थैंक यू
आम एटा प्रथम थर सांग सहित कनेक्ट करूचे एते सेंसिटिव कथा को गले ना दिन पूरा नष्ट हो जिवो पे स्केल आमे निश्चिंत पाइबा काम करूचे पाइबेनी केमती परिश्रम झाड़ बोउची झाड़र धन हमको मिलिबो टंकार नहेले लोक रिलेशन हूँ गोटे एटीएम कार्ड घसीदेव आमको बाहर जीव आम कौन टंकार केते कौन किनी पारे टंकार देखिए ये डाक्तर को बसैले मुझे मानजी सर टंकार आम बसई पार आपन सर टंकार मुझे आनीपारि टंका नुह सर रिलेशन हूँ गोटे एटीएम कार्ड घसीदबा आम रिलेशन बनाऊे थैंक यू सर
Over the stage to our organizing secretary, Dr. Shivani Shankar Tripathi, sir.
Respected PP sir, and within 6-7 days you will all will come from different districts. I just sit with Dr. Sandeep Singh that you ask the people that somewhere Jajpur, Koraput, different district they will come within a short period of time. This program, in my mind, why this program will come, in 2014 when one patient discharged from my hospital to a district like Kandhamar or Koraput, he will ask me, sir, who is my physiotherapist? I told, I don't know anybody from Koraput or Khandagiri. I know Bhubaneswar, Cuttack. So that thing I will get in my mind that in all over Odisha, so many good physiotherapists, those who are qualified and experienced physiotherapists will get together and connect. We share our knowledge. Today, whole day program is not PowerPoint presentation. We will discuss like a panel discussion. Dr. Sandeep Singh is expertised in robotic knee joint replacement. So we have getting a question how this knee replacement is in a manual and the robotic. He will explain us and we will ask the question. So this is a panel discussion. The bridge between a physiotherapist and a doctor, not only orthopedic, neuro, gynae, cardio, so many doctors are there. So I thanks to the organizing team and Dr. Amlan, Dr. Amulya, Ashish and so many physiotherapists will help us within a short period of time. We will arrange these types of program. I will not waste the time. We will go for the next panel discussions. And lastly, I will thanks to all the guests and dignitaries. Now we will close the welcome session. Next we will go for the panel discussion. Thank you so much. Now I request to
फिजियोथेरापिस्ट भारत सरकार जो अणु क्षुद्र मध्यम उद्योग मंत्रालय सहयोग आज श्रीक्षेत्र फिजियो मंथन 2024 कार्यक्रम अतिथि मानकर करकमल उद्घाटित होती। प्रिय राज्यसभा सांसद ए माटीर महक ए माटीर प्रतिभा जी सब परिवेशर कथा कहते रक्तदान कथा कहते स्वास्थ्य सेवार कथा कहते सुभाषिष खुंटिया को आज मंच प्रणाम करुछि। आम सहित अच्छा डॉक्टर संदीप सिंह, डॉक्टर पीपी महांती, डॉक्टर सूर्य प्रकाश चौधरी, डॉक्टर रश्मिरेखा महांती, डॉक्टर शिवानी शंकर त्रिपाठी। रही फिजियोथेरापी टू फिजियोपैथी एक नुआ अध्याय।
Definitely the outcome will be very good. So if a surgeon is successful, then there must be a competent physiotherapist with him. That's why so we are proceeding to the part. So my question to Sandeep sir, sir, please give a brief introduction about exactly how AI assisted joint replacement is different from traditional joint replacement. Sir.
So before I say about AI and robotics, I like to say whatever you said about the two parts of the coin. See, I am a firm believer in that. So if you ever work with us and if you come to visit our team, you will see that in our rounds, if the physio is not there, our round will not start. Right? We are very lucky that we work with excellent physios. And the thing is, we will not 3 months now. She cannot sleep because FFD is so painful. Right? All the
sir to judge the panel.
So what is the cost difference between cost difference?
Welcome to Care Hospital, sir. Zero.
No, cost difference between manual and robotic.
मैं बोला the most. We subsidize it a lot. Right? There is no cost difference.
Until post-operatively, this keep extra. I was having madam was asking some question. your patient is having what is a weakness that has to be dealt properly, generation and all, and you have to mobilize the patella properly. Then you go for the sustained stretching. Even you can ask the patient to by some elastic band or anything, or sandbag, something like that. You have to keep the stretch maintained at least for 10 minutes or more than that. If it is more than that also, that is going to end over, biomechanically with the grip phenomenon, this is going to mobilize.
Sir, MET also helps a lot.
MET also helps. But when there is a fibrosis, you have to relieve the fibrosis by giving, but you can, in relieving the fibrosis quite effectively. Rather than simple MET, conventional MET with the muscle, pick it up properly at the fibrotic site and ask the subject to do static body press, release at various fibrotic site adhesive. Thank you all.
Thank you, sir. Anyone else having any questions? Thank you so much. Now I would like to call upon stage Dr. Ramlan Mahanti, sir. Give a big round of applause, please.
Ready पछुए सर
Srikhetra Physio Manthan. हे प्रभु किए जाने केते पथ गोपीनाथ रु जगन्नाथ केते तृप्ति सरल लवणी रु छपन पौटी भोग हे ईश्वर हे पूर्ण ब्रह्म हे नाद ब्रह्म हे दारु ब्रह्म तांकरी पद पद्म रे आज प्रिय अतिथि माने आलोचक माने आज श्रद्धारे ए पवित्र माटी रे पहुंचचंती श्रद्धार स्वर
We'd like to felicitate Dr. Surya Prakash Chaudhary, sir, for please give him a big round of applause. Because of his busy assignment, Surya Prakash sir needs to leave the program early. Thank you for his presence. Thank you so much, sir.
Let's welcome Dr. Priyabrat Ojha sir, specialized in pediatrics and manual therapy, and Dr. Srikhetra Patra, MPT.
Sir, camera में ना अच्छी कौन है Dr. Srikhetra, I welcome you all. So we'll initially discuss the spinal deformity and its management by differential. So
Spinal deformity basically divided into three types: congenital, idiopathic, adolescence, and adult. Congenital scoliosis is usually seen from the birth. The baby born with some amount of scoliotic deformity in the back. In adolescent scoliotic deformity, it is the most common form of scoliotic deformity, and it usually develops when the child grows in his age. Adult due to the degenerative lumbar spine diseases or any other pathology like tuberculosis or any kind of secondary pathology, adult scoliotic deformity are exists.
Sir, is there any diagnostic tools for the spinal deformity in pediatric and adolescent and elderly age group?
Yeah. The diagnosis basically depends the patient walk and how the patient behaves. If you see the scoliotic patient, one shoulder has not matured skeletally. So we have to observe him, do proper trunk muscle exercises, give proper brace and follow, and measure the curve angle accordingly. After the skeletal maturity, we will go for surgery.
So now my question is, in this spinal deformity correction, only fixation and osteotomy are going on, which fixes the spine. So to stabilize, we are losing the mobility component. So is there any option where we can restore the...
Fusion is the surgery. Fusion means there is a huge curve. You have to straight the curve and you have to fix. If you try to preserve some amount of mobility in the apex or in the lower, in the top portion or in the bottom portion, but it cannot preserve the mobility in this patient because the mobility will harm
body. Every part of the brain represents every part of the body. So depending upon the location of the stroke, the symptoms or the signs and symptoms accordingly. And we all know stroke is two types of stroke is there. One is ischemic stroke and another is hemorrhagic stroke. Ischemic stroke where the blood vessel, the clot and the circulation will be compromised and the part of the brain is ischemic or penumbra part will develop or gradually infarct will develop. And in hemorrhagic stroke, there is a rupture of the blood vessel due to loss of risk factor. There is the lipohydration of the blood vessels, and then blood vessels get thinned out and finally it ruptures. Depending on the location of the hemorrhage, the symptoms will be accordingly the symptoms will appear. So one thing you all remember for the physiotherapy point of view, any sudden neurological deficit, the definition of the stroke, why the definition is the sudden neurological deficit. If that any deficit is sudden, so it mostly more than 90% must be stroke, either ischemic stroke or hemorrhagic stroke, depending upon the patient profile and after the CT scan or imaging study. But to simplify the symptoms of the stroke, normally which we are using this mnemonic B fast, B-E-F-A-S-T, B fast. This is the mnemonic of the stroke. B means there is a disturbance in the balance. If the patient will feel sudden disturbance in the balance, patient is unable to walk, patient will, the gait will be ataxic, incoordination of the gait, that is for the B. Then E, any eye signs. Eye signs means if there is sudden vision loss in the one eye or both eye, depending on the part of the brain affected, or any disturbance of the vision also, like blurring of vision, double vision. So these are the also symptoms of the stroke. Then coming to the face, F for the face. Face, is there any drooling of the face or any facial deviation or any facial numbness, anything sudden onset. Just one thing you have to remember, the sudden onset. If there is gradual and progressive onset, so stroke should be excluded. Then coming to the A means arm. But we are commonly representing arm and leg also. There is any sudden weakness in the arm or one part of the body, one hand also, one side leg also, sometimes one upper limb and one side upper limb and one side lower limb also. Any weakness or any sudden numbness or any sudden paresthesia, depending on the motor cortex stroke is there will be weakness. Thalamic stroke is there should be paresthesia or any sensory disturbance. So depends on the location. So that comes with A. Then S means speech. If there is in the disturbance in the speech, means patient is unable to speak, or patient is able to speak but the speech is slurring speech. Sometimes dysarthria. So this also comes under the symptoms of the stroke. If there is sudden stroke in the frontal temporal area, the patient may be unable to speak, that is aphasia. If any cerebellar stroke, the slurring speech will be there. If any motor cortex stroke is there should be dysarthric speech will be there. So this is the simple mnemonic. We first we are using this term, and lastly T is the time, because it's important to give importance to time, because the time to symptoms onset and to the hospital to the needle is very important nowadays, so that we can treat maximum to maximum stroke patient and to minimize the morbidity and mortality also. And we are trying to increase, we are trying to try to the patient should get functional recovery after the stroke also. So this is the common symptoms we first, as I told.
Thank you, sir.
Please welcome Mitali Kara ma'am with a big round of applause. Thank you.
So now my question to sorry sir. Sir, whether we can predict whether it is an ischemic stroke or hemorrhagic stroke without any radiological investigation?
Yeah, that's a good question. So you see that is very minimal difference, clinical minimal difference, saying that 7 to 96 hours, but in different situations also, hematoma size also can be grow up to 5 to 7 days also. So there is from the onset also there is weakness may be decreased or deteriorated. So that is suggestive of some sort of hemorrhagic stroke. But in ischemic stroke the weakness is sudden within second, and it will be safe. There is not further more deterioration or progression of the symptoms, and very rarely you can localize ischemic stroke because there is a particular clot in the blood vessel according to whether SA territory affected or MCA territory affected or PCA territory affected or any small vessels. So you can also localize the symptoms. If you present suddenly patient present with the one side finger weakness or hand weakness, mostly it may be a ischemic stroke. If dysarthria is there, so it might be a ischemic stroke. So there is a little bit clinical difference, but always the imaging is most necessary to confirm.
Upper limb, the synergic pattern develops very soon. So first thing is we have to focus on the positioning of the upper limb and lower limb. And that's what we educated to all the staffs, those who are working in the hospital. It's not like 24-hour physiotherapists will be there to take care of this. So the nursing staff, we should teach the nursing staff also how to maintain the posture, position of the limbs at the during the stay in the inpatient or in the ICU, all the things. Even we have to teach the family attendant or family members also.
Thank you, sir. My question to Mitali ma'am, are there any challenges in treating CBA patients in unconscious stage?
Yeah, definitely. Anybody unconscious, be it for CVA, be it for neuroinfection, be it for any reason, it is difficult to treat. Why? Because your airway gets compromised. In any altered sensorium, in a low GCS patient, airway gets compromised and there is a high risk of aspiration. By airway, I mean windpipe. आमर जो देह रे आमर फूड पाइप आउ जो विंड पाइप दीटा जिनस ट्रैकिया आउ इसोफेगस से दीटा जाक पैरेलली जाउची आ पाख पाखरे जाउची पूरा लागी लागी की हैला तो सेइथरे कोन हुए जेतळे भी हमें अनकॉन्शियस थाउ अन्य मनस्क थाउ आपण नोटिस करथिबे खाइला वाला को जदी फोन आसी गेला हठात आंसर करले आपण को हाकुटी आसी जा हिकअप्स आसी जा the reason is that both the tracts are parallel. So what happens whenever there is unconsciousness, aspiration, unrequired aspiration of the saliva or food particles from the mouth can happen into the windpipe, which is very closely placed and they are parallel to each other. So there is a very small tissue which actually guards this, these two coverings. And when there is unconsciousness, the muscle gets lax, the tone is less, and this aspiration can happen. So the patient bhavan to achieve was stroke. The patient has landed up for stroke, but now you are giving, if you are not taking care of the airway head position, then you are giving that patient aspiration pneumonia free with the stroke, isn't it? So that is something which has to be dealt from the emergency, from the arrival, from the emergency arrival, from the ambulance itself, like the head of the patient is in which position, whether there is seizure for after which he has become unconscious, whether it can be made left lateral, or if there is head can be made up at least 30 degrees. These are small things which can actually prevent micro aspirations and a long-term risk of aspiration pneumonia. That is the primary thing. Second is in elderly patients, the dentures are very loose. We have seen patients where they are unaware that denture was loose, like the attendants are not knowing, and they have aspirated their tooth only. The tooth is going into the trachea, or during intubation the loose tooth gets broken and it goes into these are small things which needs fine examination, and like you have to be aware, you have to make your paramedical staff aware of this thing. Apart from that, oxygen, third important thing is oxygen saturation also helps in early bowel movement, early involvement of cognition. In cognitively also patients recover better if the exercise is instituted, physiotherapy is instituted from that day zero as far as possible. Obviously if patient is going to OT or something, then we have to delay to next day, but in most of the cases, 90% of the cases, physiotherapists who work with me are they know that from the day zero physiotherapy should be the part of it, the whole holistic care, because stroke recovery is a lifelong process. It starts from the patient first interaction and it goes on till the time patient is surviving.
Now my question is to Priyaval sir. So in hemiplegia, would you prefer motor relearning program and CIMT, constant induced movement therapy? So MRP versus CIMT. So when will prefer the MRP and when will prefer CIMT, and what is the opinion, sir?
According to it, just after the patient gets the physiological stability, and MRP, that is motor relearning program, is for upper limb, lower limb, as well as for the face and tongue also. So in that case what happens, we have to find out which component is missing in the particular functional activity. So accordingly we have to practice the missing component, then followed by the whole activity. But in the CIMT, latter stage only we practice CIMT on the upper limb only. So in that case, the movement of the sound limb is restricted, and we force the patient to perform the functional activities with the involved side.
Now a question to Siddharth sir. Is there any role of assistive devices in hemiplegia? If yes, then could you please elaborate?
Yes, there is a role of assistive devices. So like devices in the sense, we can give the devices, but we have to check what is the stage. So whether the muscle is flaccid or not. So mostly what happens, all give the devices like braces they will give, and they forget to strengthening of the particular muscle. So again the dependency will happen. So what we have to first see, if the patient is able to do little bit of movement, don't give the device, then try to motivate the patient to do it actively. We have to focus on the muscle strengthening rather than creating the dependency. And second thing is, so assistive device in the sense we have to modify some environment also, starting from the bedside to the each and every part of the home where she or he will be able to move. So we have to modify all the environment, like from the floor, or the support in the bar, bar support should be there in the room to help in the working Then in the bathroom also, there should be specific modification, and that will be help more. And the family members should also be aware of that, like how to help the patient, so the patient will be useful, like how to use the devices. But I don't prefer the first thing is it's not create the dependency on the devices. So it should be the patient should be independent as soon as possible.
Now my question is to Priyavar sir, whether there are some patients with recurrent stroke and they are coming to physiotherapy. So any precautions should we take during their treatment?
Mainly during the clinical practice, what we have observed that so many patients they have hypertensive patients. We have to check the monitor the blood pressure first. Then only we allow to do the exercises and other things. And also we have to advise them to restrict some their personal factors like smoking and other things, regular checkup of diabetes and hypertension, etc. So all these things we have to take care of.
Is there any role of electrotherapy in hemiplegic patients?
Electrotherapy, in some literature, I found that in case of shoulder hand syndrome, there is the application of TENS in various aspects of the upper limb. So it will reduce the pain due to shoulder hand syndrome or reflex sympathetic dystrophy or CRPS. And nowadays, functional electrical stimulation is widely recommended for to gain the functional activities for the upper limb as well as for the lower limb. In some literature, it is also found that for the wrist extension, Faradic stimulation is also applied, and peroneal nerve stimulation also helpful in the dorsiflexion of the ankle.
Thank you, sir. My question to Mitali ma'am. Sometimes we encounter with post-stroke depression, and what is the cause, and could you please elaborate what is management, ma'am?
Post-stroke depression happens to three people, I will say. It happens to the patient, it happens to the patient caregiver, and it happens to the neurophysician also. Why? Because they are like, what happens is, suppose they have a big stroke and they landed very late, 48 hours, 3 days, 3 din hai gala, tapar asuchanti. So we also have very less scope to make a magic happen. So what they think, neurologist paku padaichu to pura mane ekdam hatha goda chalibo hi. It happens in limited cases. And I would include fourth is physiotherapists also, actually, who are in this post-stroke depression, because they repeatedly keep asking. The hopes are very high. When the recovery will happen, why the power is not improving from say 0 or 1 to the functional level, at least 4. And they repeatedly have that question in their mind, why I am not recovering, I am taking medicine time to time, why it is not recovering. So they do not understand the science behind it. And so even if you try to make them understand, it's very tough. And the patient gets frustrated, the caregiver gets frustrated because they are staying with the patient, and we get frustrated with the questions. And physiotherapist also feels that repeatedly we are doing, the patient is repeatedly asking. Because as a team, the neurophysician and the therapist understand why it is not recovering, because the cells are dead. Neuronal plasticity takes time, and it takes lot of practice and lot of patience. But these things, the patient and the patient party does not understand or take it in a very positive manner. So widespread awareness is the key to for alleviating this post-stroke depression, along with some medications which can actually alleviate their anxiety and depression. There are a lot of SSRIs which can be given, which have low sedation, because if we get lot of sedation, the whole exercise is lost. If the patient is sleeping only, you cannot help a sleeping person, no? So it has to be dealt very sensitively. Science has to be explained. And they have to understand one very important thing. Often my team of therapists, they often tell that ma'am patient pura frustrate कर दउछंदी, same question पचारी पचारी केबे भलो हबो केबे भलो एते एक्सरसाइज काहे करबी जदी किछि होउनी तांको एटा हमें आंसर दबा कथा. These exercises होउछंती गोटे प्रकार रो आपण यूनिट टेस्ट की एग्जाम में प्रिपेयर करछनी दिने सेटा डेफिनेटली हेल्पफुल होउछि. तो डेली हमें पढ़ुछंती केमिति सेमिति small exercises is getting stored, it is getting converted to neuronal plasticity, and in long term it is going to help your muscle reservoir, it is going to prevent atrophy. तो नेगेटिव पार्ट टाकू तांको बतेर अछि कि डिसयूज एट्रोफी हे जिवो जदी आपण एटा करिबेनी स्पैस्टिक हे जिवो कि सेही जिंस गुडा तांको पॉजिटिव रखिया बहुत दरकार अछि. डायरेक्ट काउंसलिंग पेशेंट सांगरे काना फिजियोथेरेपिस्ट होचंदी सबुटु मैक्सिमम टाइम स्पेंड करंती ताठु टिके अधिक न्यूरो फिजिशियन आ ताठु टिके कम सर्जन माने बेड साइड दे स्पेंड लॉट ऑफ टाइम इन द ओटीज बट बेड साइड हमें बहुत कम टाइम स्पेंड करूछु. थेरेपिस्ट माने नर्सिंग माने मैक्सिमम टाइम से माने जेते थोरा पेशेंट को छूचंदी हमें बोले से थोरा ताकु टच भी करूनु. तो सेठी में तांकर कांटेक्ट तांकर जो आई टू आई कांटेक्ट करके तांको विश्वास दिलेबा कि हां एटा भलो हबो, कीप ऑन डूइंग द एक्सरसाइजेस, यू विल बी बेटर. मोटिवेशन is something which is going to decrease this post-stroke depression. Also showing the videos of old patients ki this is how the patient has recovered after 1 year of mehnat, 1 year of constant sustaining on the same rod, same dynamometers. The patient has improved, now he is eating himself. These kind of motivational things actually make an impact and which can decrease post-stroke depression both for the patient and the caregiver both.
As the panel. Thank you.
On the size of stroke, the age of patient, whether old comorbidities are there or not, how quickly the patient arrived at the center, how well the BP was controlled, how well the sugars were controlled, how motivated the person himself is. There are so many factors which are involved. There are patients who have made some progress, are able to at least take a spoon to their mouth. And there are patients who have smaller stroke, have just lost a finger strength, but they are so frustrated, so demotivated that they are like, so there are a lot of factors which actually lead to recovery, and we are just the bystanders on this road of recovery, isn't it? So if there is a which can actually determine the stroke recovery, and in general hemorrhagic strokes usually recover better than ischemic strokes. If we are talking of the same age, same gender, same kind of ethnical background and comorbidities, usually hemorrhagic strokes recover better. The reason being, in hemorrhagic strokes, the bleeds, the usually fibers just get separated. They are not burnt out. Usually it's pressure effect which causes lot of damage. So that is the main reason the hemorrhagic strokes actually recover better, provided everything is, other things are same, if we consider two patients of the same size. And I hope it answers your question.
And another question, prognosis after surgery.
After?
Surgery.
After surgery, I think surgeon is there with us, we should take the opportunity and...
For hemorrhagic stroke, probably maybe if you do 100 of surgeries, complete physical recovery may be around 10 to 15% only, because 50% of the stroke patient with hemorrhage do not reach the hospital, die on spot or on the way. Rest 50%, half of them get cured. So there is a long way for us to go, and to make this 10-15% patient to at least 80 to 90%, lot of researches required, lot of timing required. Transportation is important, physiotherapy is important, proper nursing, proper rehabilitation, everything is important to get the better outcome. And we should all mix together and discuss together to make this outcome better in future. Thank you.
Yeah. Post stroke, if there is spasticity and it is disabling the physiotherapy care and the exercises, And also if it was a hand which was like suppose right hand, and if there is it is going to enhance the gait, then definitely there is a role of post stroke spastic patients. In those spastic hemiparetic patients, Botox has definite role and it should be encouraged. The only problem is that we have to repeat the Botox once because it is a time sensitive thing. So after suppose 12 weeks and 16 weeks, the Botox, the effect of that botulinum toxin goes off, and so that injection needs to be repeated. So that they have to understand. It is not usually not a one-time thing. Suppose somebody is giving consent and we have not told them that you may have to repeat the Botox, they'll come and give, they'll get angry why you didn't tell it has to be repeated, because again it's a costly thing. So anything costly, tell them, counsel them properly, because it's a long-term impact.
Thank you, madam. Another question to Dr. Biswaranjan sir. Sir, a young adult patient having scoliosis, the growth plate of the bone increases. So that time we should go for surgery or we have to wait, like a 14 or 15 years age that has scoliosis, the Cobb's angle is more than 45 or 50.
Yeah.
That stage we have to wait to the age, or we have to go for the surgery with the advanced growing plate.
Yeah, growth rate.
Yes.
It is more than suppose more than 50. Usually go for surgery, but if the skeletal maturity is not there and the deformity is severe, say around 80 degree, 90 degree, you cannot wait for the skeletal maturity to occur. You directly go for surgery with a growth rod. And nowadays there is some beautiful concept. There are some instrument. You can put the growth rod and increase the rod length from the external side through a magnet. You need not open the patient again and increase the rod length. You can do it from outside only. No repeat surgery. But it is costly.
Sir, about neuronavigation.
Yeah.
What is neuronavigation and how it is helpful for the neurosurgeon?
Yeah, neuronavigation is very good thing. It is just like artificial intelligence. Suppose you are in scoliotic deformity, the whole vertebral body is rotated and tilted. In that case, you can put the screw directly. So through navigation, the navigator will show the direction in which way you will go and put the screw, and it will give the detailed anatomy of the spinal cord. And for the brain, it has also very important role, because earlier we are doing a big flap to remove a tumor. Nowadays, through navigation, we map the tumor size and we just put the marker just anterior to the tumor and posterior to the tumor, and just remove that amount of bone required for the removal of the tumor. No extra bone rejection is required. So navigation is mandatory nowadays. So many hospitals have navigations, and we are almost doing most of the cases through navigation.
Thank you, sir. Last question to Dr. Mitali, madam, thrombolysis. How much effective thrombolysis, early thrombolysis, is it helpful or it's
very, very, very helpful. Very helpful. More helpful than the phones we are carrying now. Why? Because this drug was FDA approved in year 1999. Even before we started using these Android touch screen phones. But the knowledge, the awareness is not there in our society at least. So the way we are taking up technology in the phone, the way we are using Swiggy, Zomato, the other Ola, Uber apps, we are taking the help of technology, we are taking the help of science. But why not in medicine? I don't understand people why they don't reach on time. Even if they have reached on time, if we tell, if somebody has reached on time and we are counseling them, yes, you are qualifying for thrombolysis, they will call some Tom, Dick, Harry sitting somewhere who doesn't know what is thrombolysis. Say कहूचंती डॉक्टर गोटे इंजेक्शन दे देबे ताले सेटा फाटी जिवो आउ ब्रेन भी फाटी जाई पारे. अरे, if you tell like this, who will understand, who will give the consent for thrombolysis in your lifetime, if at all, because you belong to the medical field, you are doctors. If at any point of time, if somebody calls you and asks you advice that X doctor in Y hospital is telling for thrombolysis and patient is in window period, please give your consent as a yes, because it is definite scientific evidence. It is FDA approved drug, and we are underutilizing this drug because it can actually make magical difference in patients who have come with zero power to going back home in at least 3 plus or 4 power. And obviously physiotherapist takes up and they come back to us with 4 plus power. So that is what I would suggest. Please say a yes, because no doctor will randomly suggest you go for a thrombolysis. It is usually a neurophysician who takes a call on this, and it's not that harmful as well. If the body weight has been judged and there is no much comorbidities, it is a definite yes.
Scoliosis around 60 degrees, and he having no pain at all. His postural deformity is there, and angle 60 degrees found in complete X-ray. Then what do you suggest?
Angle is 60.
60.
So
60
you,
or above 60.
yeah, then you give the proper brace.
Yeah.
Brace should be used at least 20, more than 20 hours per day.
Yeah.
Now the braces are very beautiful. They can be used in a comfortable way, and the child can go to the school. He can play with the brace. He can do everything with the brace.
Sleeping also, sir?
Yeah, yes, it's possible. Possible.
But at the age of 12,
We should not go for surgery at that time. You just improve the strong muscle strength. Because most of us think that the muscles are only in our hand and leg, in the upper extremity and lower extremity. We usually forget the muscles of the back and the trunk. So, improve the muscle strength of the back, improve the pulmonary function test, do proper physiotherapy for the lungs, and proper bracing.
Yes, sir. One of physiotherapists suggests for matrix therapy for 3 months. After that also the angle is not improved.
No, at least use the brace. The angle will not deteriorate further, because if you will not use proper exercise or bracing, the angle will go from 60 to 90 degree. So after 17, 18 years, when I am going to do the surgery, I will face a lot of difficulty in correction of that angle. So 40 to 50 degree, 60 degree is better to correct than correcting a 90 degree angle with a lot of comorbidities.
How much we wait for the patient to do
Till the skeletal maturity to occur, or if the pulmonary function deteriorates, if the visceral function deteriorates, we have to go for surgery with a growth rod.
There is no problem, no problem for anything.
If nothing problem, then you go for conservative management at least at present.
Okay, thank you, sir.
डिसेबल होकर रहा निज कम कर फाइनान्शियल बर्डन फैमिली पड़ा फिजिकल बर्डन पड़ा से आम कह कहीं से मलानी तेणु ये क्वालिटी ऑफ लाइफ खाली सर्वाइवल नुहे क्वालिटी ऑफ लाइफटा इंप्रूव होगा दरकार एवं क्वालिटी ऑफ लाइफ इंप्रूव होगा फ्रॉम द वेरीफाइड फिजियोथेरेपी इंटरवेंशन इज रिक्वायर्ड as told regarding the positioning play a very important role that prevent appearance of the primitive reflexes, spasticity, abnormal movements, etc. and that normalize the posture, normalize the tone. So simple positioning of the neck. We talk about the limb positioning, not only the limb positioning, most importantly the positioning of the neck. Neutral extension position that facilitates the breathing, that may prevent the aspiration, that prevent the primitive reappearance of the primitive reflexes that affect the tone and posture. So that is very important. Simple, nothing should be placed in the hand, nothing should be placed in the foot that may provoke the spinal level reflexes, the grass reflex, and no splint. Absolutely no splint. When I go to neurology, what we usually find, the attendant are giving vigorous massage and vigorous relaxation movement. They think, vigorous is the movement and massage, the recovery will be fast. But that is going to lead to various complications like dislocation of the shoulder. Once the shoulder is dislocated, whatever you do, no recovery of the hand is expected. So positioning is very important, and those, simply you
give a hip and knee flexion just once. That will prevent, the tightness, contracture, and range of motion will be maintained. It is not required to give vigorous movement of the muscles. So from the very even in the emergency phase also, physiotherapy play a very important role in recovery of the patient.
Yes, sir. On a wheelchair, as early as possible. Even if the patient is tracheostomized, I ask the patient to wear a Philadelphia collar. Through the hole, the tracheostomy tube get accommodated, and the patient gets seated on a wheelchair, and the patient attendant move the patient for at least 1 to 2 hours per day. Yeah, cranioplasty is not a cosmetic surgery. There are a lot of papers. Even I have a paper on that. The earlier you do the cranioplasty, the better is the outcome, because atmospheric pressure is there. The bone is protecting the brain from the atmospheric pressure. Okay, if you remove the bone, the atmospheric pressure will directly fall on the brain. So
actually, sir, I have another question with this. Basically, I'm working in a neuro rehabilitation center. There we have patients who are being done craniectomy, but after 3 months, 4 months, still they are waiting for the surgeons to go for a cranioplasty. And in between that, they used to go for cardiac emergencies. We have a patient, she is only 36 years old. After 15 days of her craniectomy, she got a cardiac arrest. Sir, is there any possibility that after cranioplasty she will be getting any recovery signs?
usually after cranioplasty, the patients improve. Usually.
So the anxiety levels and other psychosomatic factors will develop post cranioplasty.
No, that the psychosomatic is different.
Yes, sir.
But the brain normal functional, that the chances that if you now the papers are there that earlier you are doing the cranioplasty, the better is the neurological outcome.
So what is the probability of having basal ganglia bleed patients recover? Basically, we say basal ganglia bleed patients they recover slow.
Slow, and functional outcome may be around 10 to 15%.
Does it have any factor with the age? If younger patients are getting basal ganglia
Yeah,
bleed?
younger patient chances of recovery is better.
And if the patient is older and having comorbidities, what is the prognosis, sir?
Prognosis is not that
Very
good.
bad, sir. Okay. Thank you so much. Thank you. Anyone else wants to have any questions? Thank you. May I request Dr. Amlan Mahanti, sir, to please give them a big round of applause. Thank you.
नहीं फोटो दे भाई टिके न रहिबो भाई
go for only X-ray after the clinical examination, of course, or MRI is needed. Of course, we can delay the MRI by 2 to 3 weeks when the soft tissue injuries or some minor soft tissue injuries would have been healed and the major ones would have been prominent. One more thing is that in an acute setting of injuries, we may not be able to do all the clinical examinations to elicit any ligamentous laxity or the injuries that you have told, like Dwyer test or for that sometimes we give some local anesthesia to relieve the pain immediately after the injuries, or we can wait for 2.
In grade 2, always grade 1 we will manage in physiotherapy. In grade 3 you will complete tier, we will go for surgery. In grade 2 tier, how much percentage of physiotherapy role in grade 2 tier? The patient is need for surgery or he may go for conservative. Good afternoon everybody.
So mostly in ACL grade 2 tear, we have to see the patient complaint, and it's like a symptom also. If the symptom knee swelling is more, sometimes I will know, in MRI will know that it's grade 2 tear, but if it is associated with other tear like um, meniscus tear, the other soft tissue injury or any muscle injury there, then we'll wait for subside of inflammation. When inflammation subside, we will go for strengthening exercise. In grade 2 to tear, usually as a physio, we will not suggest to go for surgery. First, we will reduce the inflammation. Then we will go for a strengthening program. After that, after minimum, we follow Oxford technique or any strengthening program. Then after 15 days, in every 15 days, we follow up the cases and see its strength and the drawer test, anterior drawer test or latchment test. If it is improving, then we will still continue strengthening program. If it is not totally improving and patient is complaining lot of pain and swelling is increasing day by day, then we will suggest to go for surgery.
And my question to Dr. Profes, as a physiotherapist, mainly in ligament injury, we have to, mainly our motto is to get strengthen the muscles and increase the range of motions. So as a physiotherapist, if you will handle the cases after surgery, how much time taking? People will ask after the surgery, how many days I will need physiotherapy? After my ligament injury, how many days I will take physiotherapy? So as per your experience, how many days to totally fully recovery of a ligament injury?
Good afternoon, sir. Actually, it depends on the patient's condition. We first examine what is the pre-op condition of the patients. The muscle grade we can check. Is there any scar or is there any associated factors are involving there? Along with the, as per along with the ligaments, is there any other soft tissues that are involved or not, like your meniscus and other factors is there or not? And another factor is that the weight and the age of the patients. So by concluding this type of factors, we can decide how many times the patients needs. If the patient is the young patients, then it will be recovered within 2 to 3 months. But the protocol which will be followed for the 3 months generally. And generally, if the patient's conditions regarding excluding the complaints, if the patient is good, then it will be recovered within a few weeks, like 1 or 2 weeks.
Thank you. My question to Dr. Abhimanyu. Sir, I am working in a corporate hospital. So many orthopedic doctors are there. Each and every doctor nowadays doing arthroscopic surgery. So the protocol of physiotherapy is different each doctor. One of the surgeon told the next day the patient is going for full weight bearing. The other doctor is telling non-weight bearing. Another doctor is getting partial weight bearing. So as a physiotherapist, first I will see the condition or the surgeon's view. So each surgeon having getting a different protocol. One doctor telling no weight till 45 days. I have done meniscus repair. One doctor, yes, you can get full weight. So what is the difference weight bearing protocol in SCL, PCL and meniscus injury as per your view, sir?
So we have two kinds of scenarios. One is isolated ACL injury, or the second case or the multiple number of cases can be ACL with PCL, ACL with meniscus, ACL, PCL with meniscus. These kind of scenarios we have. So the different guidelines, American Association of Orthopedic Surgeons or even the Indian guidelines also, like senior surgeons who have done thousands of these kind of surgeries, the one thing they emphasize is mobilization. Mobilization and weight bearing are two different things that we should understand. Some surgeons are a bit hesitant to ask the patient to bear weight on the next day, but mobilization, I think nobody tells not to do. All of them tell to do. First start with closed kinetic chain exercises, then increase the range of motion, and then do open kinetic chain exercises. So for me, the protocol, if ACL is only reconstructed for the patient, then we can do mobilization as well as weight bearing with long knee brace and the walker support from the very next day of surgery. if ACL and PCL are repaired at the same sitting for the patient, then we can do mobilization and weight bearing. We can wait for at least 2 weeks till the sutures are removed, because PCL being a more greater stabilizer of the knee, so we need bone to ligament bonding so that we can rehabilitate the patient better. And if ACL, PCL and meniscus are injured, the meniscus repair or excision, we have to differentiate. We have only excised, then we can, with ACL, then we can straight away start weight bearing like only ACL injuries. If we have repaired the meniscus and it's in the peripheral zone, red zone, then we need to wait for more than what we are waiting for ACL and PCL, because meniscus gets its nourishment from the synovial tissue and the surrounding capsule to which the periphery is attached. So for me, ACL immediate weight bearing, ACL plus PCL wait for 2 weeks at least, ACL plus meniscus, ACL plus PCL plus meniscus wait for at least 1 month for the meniscus to heal ideally.
My point of view is that choosing of graft, you are taking a quadriceps graft or a peroneal graft. Sir, which graft you are taking, using?
Graft most of the times is decided on the patient age, the activity level of the patient and the physical stature of the patient. If the patient is an athlete who is into high density sports, then mostly the difference is between ACL and PCL reconstruction. ACL anatomically is thinner as compared to PCL. So definitely for PCL, for any kind of patient, I will go for peroneus longus graft. For ACL, there is a bit difference. I have to differentiate between the patient category. If the patient is a female patient who is not into much of activity, then peroneus is straight away, because most of the times when we open the semitendinosus, we get it very thin. We have to augment along with gracilis and internal bracing to get the required thickness of around 8 to 9 millimeter of graft length. So for PCL straight away it is peroneus longus. For ACL it is if the patient is a daily laborer or doing heavy physical activity every day, then semitendinosus will do. For female patients, both semimembranosus and semitendinosus and gracilis, or else if straight away we can go for peroneus longus. Bone patellar tendon bone graft or quadriceps tendon graft, we mostly reserve it for revision cases.
Thank you, sir.
Sorry to interrupt. What Dr. Shivani told, that why doctor has different opinion regarding duration of weight bearing or duration of range of motion.
I think this is not regarding the what guidelines say. This is what personal experiences regarding this recovery in the post-operative period for a particular surgeon is concerned. What I think that because the graft, see, the common cause of failure of any ligament surgery is the initial strength or the tightening of the graft what you have taken. What I think that previously the technique for ACL surgery was transtibial, transfemoral, but now we are doing it transtibial once, and the femoral tunnel is slightly oblique as compared, it's not through and through. So because it is more anatomical, the previous guidelines for keeping the patients immobilized or non-weight bearing for a prolonged duration of time, for example 3 weeks post-operatively, was there, but now it has changed. But since they have started with transtibial, transfemoral tunnel, and now they have shifted to this different tunnels for both tibial and femoral side, but they have the physiotherapy protocol they are not able to change because they think that sometimes this might give do more harm than any good for the patient. So I think they need to change the mentality rather than this anything else, because most of the studies have told that isolated PCL injuries, you need to mobilize the patient straight away day after in POD1.
I think in my point of view, sir, like in morning we discussed about a robotic surgery. Knee replacement, like, it's not a emergency surgery. Ligament, if this is not a RTA case, if this is a planned case during playing football or during anything, if 15 days before 2 weeks we will go for strengthening program, then after we will go for ligament reconstruction or meniscus reconstruction, the result will be better as per my experience. It's not a like emergency. If RTA, that is a different case, we have to go for like avulsion injury, that is a difficult case, we have to go for immediate surgery. But if this is a planned case, we'll go for 2 weeks pre-rehabilitations, strengthen the muscle, get the range of motion, then go for surgery. I think the result will be better.
Yeah, while I was in Amri with Sibani sir, we have discussed this a lot of times previously, that rehabilitation is very important for any active athletic individual to get into pre-injury stage. Like prehab is very important for any surgery to be successful, of course post-operative rehabilitation as well.
My question to Dr. Amulya Prusti. When you get a patient post SCL 2 months, the stiff knee like a arthropfibrosis, the end range is bony, range of motion is bony, not like spongy, very hard. In that case, you will try for physiotherapy or you will send the patient to a surgeon for arthroscopic lavage. You have to try it, or you have to, after 2 months of cases, severe deformity, flexion deformity.
Usually this happens due to quadriceps acne. So it depends age of the patient, musculature of the patient, and the muscle. Different patient has different muscle structure also. If musculature is good, good musculature, it is very difficult to get the range. If musculature is thin, then we can add some weight and give some stimulation, whatever paradigm under tension, then it will have good result. But if you are saying it's bony restriction, it's not bony restriction. It is the quadriceps muscle get tightened. If it bony restriction, then patella there is some you can see in the X-ray that there is some restriction. You can go for any arthroscopy surgery.
Quadriceplasty, sir, how much successful quadriceplasty? In this case, we'll refer.
That I think physiotherapy along with help of machines like CPM will help to get the full extension and flexion. Some restricted or end range of flexion restriction might be there, which the patient will, mostly the patient do not agree for a repeat surgery if I have done an index surgery or primary surgery. So some kind of flexion deformity without any hindrance in the activities of daily living, they mostly go on.
Lack of fitness is another problem. Nowadays, in our time, what happened, we used to play. In school there was fitness, but nowadays we are all busy with mobile and all those things. So fitness, there is lack of fitness. And number two, whenever you go to a following injury to a physician or the surgeon, the first thing nowadays they go for the investigation. Now the medical treatment is based on the investigation. So obviously when you immediately go for the MRI, it has to be diagnosed early. Then my one question is to Dr. Abhimanyu, after how many days of injury you should go for the MRI? Because after injury there is lot of effusion, there is lot of hematoma, there is every possibility that false positive sign you may get.
So MRI right away to me with some kind of soft tissue injury. I take an X-ray. Patient come with a MRI without having done any X-ray right nowadays. So I tell them that do an X-ray. If no bone injury is ruled out, any kind of bone injury is not there, then I tell them that put your knee in a long knee brace, give some analgesics, enzymes and all, and then ask them to wait for 3 weeks, because clinically it is difficult with so much of pain to elicit even grade 2 injury. Grade 3 injury, okay, the patient will tell that I am having instability while walking or climbing stairs and all. So 3 weeks is my time. So even if they have come with an MRI, I tell them to repeat after 3 weeks, because some structures would have healed by then. and then the larger or the more important structures we can get a picture, because grade 2 injury we need not operate in a non-demanding patients. So I think that we are operating more of grade 2 injuries right now with within these 3 weeks if we are doing an MRI and straight away jumping for surgery.
The surgery again, it depends on the age of the patient and active level of activity is more important. What is his occupation and what is his level of activity? If a sedentary person, maybe it can be managed conservatively. Even grade 3 injury also can be managed, I think, conservatively. An elderly person, again, the level of activity is reduced, that we have to find out. And regarding physiotherapy part, post-operatively, nowadays, no one go for the immobilization. Immediately you have to go for the CPM, which press the CPM, continuous passive motion has to be given. And regarding the exercise, again you have to follow the biomechanics. The simple thing is, if you go for the open kinetic chain knee extension, that there is anterior translation of the tibia, where in case of ACL injury it has to be avoided, and in case of open kinetic chain knee flexion, throughout there is a posterior translation of the tibia, so that has to be avoided for tibia, and stress or strain the reparative site or surgical site. And of course the strengthening, and before the sports person, before returning back to activities, this proprioceptive training is very important. Balance training, proprioceptive training is very important. And post-operatively, I think, suppose is a sports person, after how many months you advise the patient to return back to activities?
This depends on what kind of means. Mostly I will ask my physiotherapist to opine what is the strength of the muscles around the knee joint, both above and below. And 3 months is the ideal time that we go for high-end activity sports.
Thank you. Any question from the audience side?
Good afternoon, sir. So my question is, how do you deal with the aspect of pain when you are dealing with knee cases? Like when you are talking about patients who are at a little bit higher age of 50 plus 60 years plus. So at that stage, when the pain is that much severe, so how do we deal with that kind of pain? It's my question to all the panel actually. Because dealing with patients who are very much sensitive to pain is a bit difficult for us. So how do we deal with the aspect of pain?
Both after injury, before surgery, and after surgery also, one thing is counseling is very important from the doctor's side and from the physiotherapist side. Analgesics will definitely continue for 15 to 20 days post-operatively. Pre-operatively also we give analgesics. Mobilization is very important for any patient before surgery and after surgery. So we have to control pain with analgesics and mobilize. There is no second thought about it from my side. Regarding pain, I'm talking about the post of surgery, right? The post of surgery, we can manage it by the positioning. If you properly place a pillow or anything else in the relaxed position, somewhat it decreases the pain. And second, you can go for the cryotherapy. And to maintain you should be go for the protections, like you should be use some splint brace in order to protect the newly implanted ligaments and all the things, and counter out what is the exact factor that induces the pain. So you can go for that one and continue his ankle dorsiflexion and plantar flexion in order to maintain the muscle property and in order to maintain the circulation and to maintain somewhat the muscle properties, and that may be somewhat help to reduce the pain.